And friends, I thank the chair, Ranjit and Pratap sir, and for this opportunity in CIOS. Good morning to you all. I'll be speaking on the PAN card plus procedure. So PAN card plus basically means whatever you do additionally other than the PAN card is called PAN card plus. Before I start, I am very thankful to each and every member of CSK, ASK, and Cochin Orthopedic Society and KOA because of all your help, I could become the secretary of the Shoulder Society of India. So it is a big dream to be part of this SE, and it is possible only because you have very good friends, mentors, and seniors. So special thanks to my very close friends, good friends, friend Shanavas, Srihari, Jyoti, John sir, Mahesh sir, Pratap sir, Jis sir, Harish sir, and each and every one of you. Thank you so much. So the question is, why do we need the PAN card plus? So that is because of the redislocation rate. If you look at the recurrence rate of a PAN card, if you just do a PAN card, it is definitely high. It can vary from 8% to even up to 30% in some literature. So now, if there is now you have to think, is there a critical bone loss? Do we have bone loss or no bone loss? If there is no bone loss, you need to do some soft tissue procedure. So that you do an addendum, that you do add something to the PAN card to increase the stability. So that is the PAN card plus. That is when you don't require any bones. This can be done by increasing the number of glenoid anchors. Minimum 3 anchors are required. You require adequate soft tissue plication. You need an exaggerated capsular shift, and you do remplissage, etc. So how do we divide it? Divide it into two as soft tissue procedures and bony procedures. Coming to the soft tissue procedure, the first is a capsular shift. What is a capsular shift? When we are doing a PAN card, we have to do a additional, that means more plication is required. So if you look at this anchor placement over here, this is one of the papers which we were able to publish, and you can see that a proper elevation is required, and you go in with a scorpion or any kind of suture passer and see how it is passed. You are passing much more deeper inside. You're going all the way deep, at least around 1 centimeter. And you also see how the anchor is placed. Anchor is placed not at 6 o'clock. You have to pull it up. That gives you a capsular shift. So this capsular shift is a very important component of your plication and in your success. So then, the research with capsular plication is always better. There is documented literature on this. So this paper shows that there is capsular plication is very important. Then coming to remplissage. So remplissage, all of us do the remplissage. There are different ways of doing the remplissage. This is a standard way. We are looking from the anterosuperior portal or a trans cuff portal, and anchor is passed. And with under visualization, you can like this, you can penetrate through the cuff and bring it out. So this is one remplissage technique. You also have extra articular remplissage. So this is a technique where you visualize where you are entering. So that means I clear the subacromial space here now, and then I visualize where exactly I want to put the anchor, and then you pass the bird beak under visualization. You have to pass it under visualization. So every time you pass it you pass it on top of the cuffs. You see in the subacromial space, penetrate, see where it is coming and catch it. So that gives you a nice separation. That means a nice spacing. You can see the spacing here, nice spacing. These are two different ways of doing remplissage. You also have a double anchor or double pulley technique is there. So you also have the knotless technique. So here, what is the importance of the remplissage? So why is that remplissage is required? Next is, if you do remplissage, what will happen? Will it actually cause any problems? So now, there is a concept of the borderline track. So I will try to, so what is, we all of us know about the on track and we know about the off track. So look at this. So pre-operatively and post-operatively, see pre-operatively 15 patients were off tracking. This after a Letacheck. Post-operatively, only 5 were off tracking. But if you add 5 millimeters to the track, additionally put another 5 millimeter more to the track, you will find that 3 more will track. This is a study which we did around like 4 years back. So means to say that the track is not an absolute concept. That means it is not like, it will, if you calculate an on track or an off track, it will dislocate, it will not dislocate. It is not like that. It is relative. For example, you are taking your hand into sudden extreme motion. It doesn't track in the proper way. So again, there is a concept also called distance to dislocation. So if your distance to dislocation is around within 8 millimeter, so again there are higher chance of dislocation. This is a concept which came around like 2-3 years back, and it is by Lin et al. And further studies by Yamamoto. So this is called distance to dislocation. All this basically tells that we have to do the remplissage as well in all cases. If you do it, you will not have any significant dislocation, or you will not have any significant rotation deficits are not there. So this is my take on the remplissage. So do remplissage in all cases, there's nothing to lose. And you will not lose much of rotation. Then rotator interval closure. So that is another thing which we can do. That is, there is enough evidence to show that rotator interval closure does definitely help, and it will help in increasing the stability. And if you do the rotator interval closure in external rotation, and so you will not have any significant rotational deficits. This is our outcome paper on a combination of Bankart, remplissage, and RI closure, 2 years outcome, and we didn't have any significant failures, and we also didn't have any significant external deficits. Coming to the DAS. So DAS is a procedure where we cut the long head of the biceps, make a split in the subscapularis, and then fit it onto the 3 o'clock position of the glenoid. So this is originally described by Phil Collins and Laderman, and we have a technique where in arthroscopy technique, where you can do this, you can see how the long head of biceps fits into the glenoid. So through a tunnel, a transosseous technique. So I don't have time to go through the technique. So there are different techniques of DAS. You can do labral reconstruction also. Then another thing was a concept which we brought about was, we can do IGHL reconstruction in extreme soft tissue insufficiencies or revision scenarios. This is a concept we got published in Journal of Isocos, IGHL reconstruction with long head of the biceps. Another technique, you can see like this. This is our another technique which I'll take another 15 and half a minute more, sir, kindly excuse me. So this is a technique which we recently came up with. So this is the patient where we did a Bankart plus. So if you look at this, what we find is, it is looking like an absolute absolution. This is a 16-year-old patient. You saw how the capsule is going all the way down. So we had to mobilize it, but you see the amount of capsular, how much redundant the capsule is. So what we did was, we did a technique of coiling. So this is the coiling. So one limb goes round and round so that it rolls the capsule. The other one goes through a single penetration, and like a lasso loop it comes and sits. So this is your coiling technique. This is an additional thing, because initially whatever I was doing, it was not stabilizing. With this, it did really stabilize. This is another capsular technique. And next you have the ASA technique or subscapularis augmentation. So this is, and then we have the Latarjet is also a Bankart plus. Latarjet can be done as a regular Latarjet, arthroscopic Latarjet, or we can also use ICPG or DBM. All these are different techniques of Bankart plus. The spinoscapular can also be used as a Bankart plus. Lateral end of clavicle, Latarjets, different types of Latarjets, and so this is basically the Bankart plus. There anything other than your regular Bankart. It could be bony, soft tissue. You choose according to whatever you want, according to the deficiency or what you need. Thank you so much.
Okay.